for the AFib clinic here at BGH. And this is Kitty. She's the nurse that works with me, yay, at the AFib clinic. And her background, she came from CCU. I stole her from there to come work with me because she's fantastic. And so we're here today to give you an update on atrial fibrillation and anticoagulation. This is a huge, huge audience, and I'm so happy that this is not only for cardiac services and allied health, but we actually expanded it to more areas because we all have to deal with patients with AFib and blood thinners, and it's new. So for a show of hands, can you just put your hands up if you're from neuro? Woo! Yay! All right. And also from Emerge. Who's from Emerge? Yay! Yay!
All our Emerge comments will be addressed to you.
And I know we have some people from critical care, from ICU, educators. Yay! Awesome. And then from Gen Surge. I heard from Gen Surge here. Any from Gen Surge? PAR. PAR recovery. Yay! And we have from not only from BGH and UBC, which is fantastic. Yay! And of course from cardiac service how about from CCU? Who's from here? BGH CCU? Yay! And CP10? Yeah! And CSICU. All right. Yay! Awesome. And also from heart failure and outpatient clinics. Anyone from cardiac rehab? Yay! All right. Super. Awesome. So as you can see, this talk is relevant to everyone across in nursing and health. So we thought we wanted to extend to everyone because we all have the same questions about what is AFib and the blood thinners. So without further ado, before Kimmy starts, I would like to thank Bear, Jeremy and Jen in the back. They're the ones who are sponsoring dinner tonight in this talk, so thank you very much. And hopefully everybody got something to eat and some desserts and drinks, and we'll start our talk right now. Also, just letting you know, if you have colleagues who weren't able to come to this talk, we're actually taping this. And so hopefully soon we'll have it available online, so people like your colleagues, if you felt that was interesting and helpful, that you want to share, just let us know and we'll get it out to you guys. So without further ado, I'll let my colleague, my partner in crime, Kimmy, to start the talk. Her better half.
So, yeah, as Pam said, I'm Kimmy. I am the person behind all those emails to get everybody here. So thank you all for showing up. This is awesome. So I'm just going to get going with the presentation because I know you guys all probably have places to be. Oh, okay. The show. Okay, so today, like you said, we're going to be talking about atrial fibrillation. Pam and I are going to do a review of the updated guidelines. So 2014, they did updates to the Canadian cardiovascular guidelines for atrial fibrillation. So we thought it would be a nice opportunity to get everybody together and go over what's new and exciting in AFib. So these are our disclosures. And so a little bit of what we're going to cover today. We're going to talk about, we're going to do the anatomy and physiology of atrial fibrillation and atrial flutter so that everybody's on the same page and has a good understanding. We'll talk about the causes and the symptoms of atrial fibrillation, and as well I'll do the treatment portion. So I'm going to talk about medications, cardioversions, and ablations. And when you're sick of hearing me talk, Pam's going to come up and she will do the stroke prevention stuff. So she's going to do the actual CCS, the guidelines for oral anticoagulation, and she's going to help us decide what are the right oral anticoagulants for the right patients. Okay. So a little bit about atrial fibrillation and atrial flutter, some quick facts. Atrial fibrillation tends to be one of those things that's progressive. So sometimes people may have episodes that start out far and few between, but it is something that tends to progress and can become chronic. It's something that occurs in 1 to 2% of the population, and it is more common in older population. So as people get older, 1 in 10 people over the age of 80 will have atrial fibrillation, but as you see here, it's about 1 in 1,000 under the age of 50. And the lifetime risk, as you turn 40 years old, the lifetime risk becomes 25%, which is quite significant, Pam tells me, for people who are 40, because 40 is pretty young, right?
Are you saying I'm over 40, Kimmy?
No. 40 is young. 40 is a new 20. So just a quick little things there. And then, so once atrial fibrillation does start, the atria, because they start changing, the arrhythmia is more likely to continue, and it makes it harder for people to get back into normal rhythm. So a little bit about atrial fibrillation, and I'm just going to embarrass myself and say this. When I was working in ECU, I didn't know fibrillation and flutter came from two different places. So I'm going to share that information with you and do some anatomy and physiology here. So what happens with atrial fibrillation is in the left upper chamber where your pulmonary veins are. So your pulmonary veins have brought all this oxygenated blood up to the left upper chamber of your heart. Where the cardiac tissue and the pulmonary vein tissue meet, that's where the erratic electrical impulses start for atrial fibrillation. I didn't know that. And when you're having fibrillation, so that fibrillating that's occurring, it's going at about 400 to 600 per minute. That's how quickly fibrillation can be happening. And then you have this AV node that's blocking the electrical impulses. So I like to think of, if you think about being in the lineup for like a bar or a club, and you have a bouncer there, and the bouncer is only going to let a few people in at a time. That's the AV node. It's like the bouncer. It's only going to let a couple of you in at a time. And this is going to result in irregular impulses, right? So typically, atrial fibrillation tends to be, and atrial flutter they tend to be fast rhythms. So usually we say anywhere from 80 to 200 beats per minute. And rapid atrial fibrillation would be at over 100 beats per minute. And slow atrial fibrillation is anything that would be under 60 per minute. Okay. So atrial fibrillation, how would we identify it on an ECG? There's some key things that we're looking at. One, I think that everybody kind of knows is that it's going to be irregularly irregular. So the first thing that you're looking at on your ECG is mapping out your R waves and seeing is this regular or irregular. So atrial fibrillation is irregularly irregular. And the classic thing that is mentioned for atrial fibrillation is that you're not going to see P waves. You might see things that look like P waves, and if you're really hunting for them, usually it's going to be, I feel like I'm not looking at this side of the room, it's probably going to be atrial fibrillation that you're seeing. The other part that makes it a little bit difficult to diagnose when you're looking at an ECG is when you have the fibrillation waves, there's different amplitudes of waves. So you can have fibrillation where it's less than 0.5, so a little more fine, and then you can have this stuff called coarse atrial fibrillation, and that can often get confused with atrial flutter, and it's something residents, fellows, cardiologists, everybody, there are a lot of people who can misdiagnose this fibrillation for flutter when it's coarse atrial fibrillation. So atrial fibrillation on an ECG, what are some things that we recognize right away? Is this a regular or irregular rhythm? I guess if I had to label it atrial fibrillation, it would be more challenging. So it is irregular. Can anybody tell me how fast this is going? Pardon? Oh, there's prizes. Pam has chocolate. She's not a very good thrower, but she does have chocolates for people who get answers. 90? 90 is wrong. Other guesses.
Who wants to
Yeah, right there. 135.
Okay, I'm not very good.
Please watch your head. Underhand.
This is from
Anyhow, so again, a quick, easy way to get what your grade is you can count all of the R's and just multiply by 6. So it's going to give you, it'll give you what your rate is on the ECG. So I can't remember what that is, but anyways, I did it in 130. And so again, you're seeing here, this is not a regular pattern, right? It's not, you're not having, and then you don't have a nice P wave before every QRS. So that's an indication that this is probably fibrillation. Flutter, a little bit different. So like I said, fibrillation is happening in the left atrium. Flutter is actually happening in the right atrium. And instead of being as disorganized, flutter is going on this pathway counterclockwise. So I think of it like a race car track. You're going around and around counterclockwise. That's what flutter is doing in the right atrium. It's more of an organized rhythm, and it's coming from the tricuspid area, so the tricuspid valves. It's a very fast rhythm, and again, how we were talking about the fibrillation that happens with atrial fibrillation, flutter, usually the fluttering rates tend to be at about 300. But again, your AV node is blocking some of those impulses from getting through. So it tries to limit to every second impulse. So that's where you see things where it's blocked, where you might have a 2-to-1 flutter. That's what's happening there. Some of those flutter waves are getting blocked. And just a little mention here, when you have flutter that's 1-to-1, it's a little bit difficult to assess on an ECG. You're going to see a rapid rhythm. It might be even thought to be other rhythms. Sorry, but the point is that it occurs in patients, they become hemodynamically unstable. It's something that can progress to atrial fibrillation. So for those of the one person from Emerge here, so this would be something that you would be urgently assessing and would be doing urgent cardioversion on. So atrial flutter, what does it look like on an ECG? How does it differ from fibrillation? So it's a narrow complex tachycardia, and this is going to be a regular, more of a regular rhythm, right? So atrial fibrillation, irregularly irregular. This is going to be more regular. And this is what your blocks can look like. So 2-to-1 is just one example. So you can have 2 little flutter waves and then 1 actual pure wave. And then the classic thing that we say about flutter is the sawtooth pattern. And that's a classic thing that you can look for flutter. So if it's regular, you've got the sawtooth pattern, likely what you're seeing is atrial flutter. Okay, and then you want to look at your inferior leads, so lead 2, 3, and ABL. Okay, so atrial flutter, sorry, is initiated by other fast rhythms. Can anybody tell me? So atrial flutter doesn't always just happen spontaneously on its own. Sometimes other fast rhythms are going on and then atrial flutter develops. Can anybody think of a fast rhythm that might cause atrial flutter to come about? Name some rhythms. Pardon? Yeah. Yes. Yes. And what we've been talking about here, atrial fibrillation. Sometimes atrial fibrillation can cause flutter to come about. PACs, PVCs, all those things can cause atrial flutter to come about. So just making sure we're paying attention to our ECGs and making sure that if you do see other irregular rhythms, atrial flutter might be something that would be a problem down the road. So atrial flutter I'm going to let you guys answer what the conduction is. This is on an ECG here. Do we think it's 1-to-1, 2-to-1, 3-to-1, 4-to-1? It's kind of... Pardon? Yeah, it's about it's kind of tricky, I guess. There are some where it could look like it's 3-to-1. 3-to-1 and 2-to-1 is kind of what you're seeing here. But you see how it's different in that your QRS, it's more regular. So if you were to map it out on a piece of paper, you would be able to see the regularity versus with the atrial fibrillation, you wouldn't be able to map it out. Okay? And you are getting a bit of that sawtooth effect happening here. So, a little fun ECG. What rhythm do we think this is? How many people think it's atrial fibrillation? Hands up. Okay. How many people think it's atrial flutter? A couple of people? Okay. Well, so actually this is what we were talking about, the defined fibrillation and the coarse fibrillation. So it is atrial fibrillation, but you have your coarse fibrillation happening there. So you can see what I mean here with the fibrillation and the flutter. They look so similar. And so again, that's where you have to go out and map that. You can see here that it is irregular. You wouldn't be getting a regular pattern if you were to map this out. So again, just a good example of how flutter and fibrillation can be mistaken for one another. So, question. So there's asynchrony that's occurring between the atria and the ventricle, right? They're not working together. So what is our reduction in cardiac output? What percentage of cardiac output is lost? 10, yes. Watch out. So, and then, you know, what are you losing? You're losing your atrial, right? So this becomes a problem with atrial fibrillation. Causes and symptoms. So we have our patient here, Nancy. She's a 70-year-old female. She lives alone with her dog. I'm going to name her dog Shadow right now because I've decided. And she comes into VGH emerge, and she's got palpitations, shortness of breath, past medical history of hypertension. This would be a very typical patient that you would see with atrial fibrillation, right to our emerge friend? Yes. So just keeping this patient in mind as we go through some further discussions here. So for symptoms of atrial fibrillation, they can vary. There are people who have no symptoms whatsoever. It's just found on an ECG. In an emerge, you might see it when somebody comes in and they've had a fall, you do the ECG, oh, they're in atrial fibrillation, but they wouldn't have known had that ECG not been done. And then other people have quite pronounced symptoms, such as you can get palpitations, dyspnea, fatigue, dizziness, angina, syncope. I was kind of laughing with Pam about this. I hope people don't look like this throughout the talk. And so if you've heard of the New York, I'm sure you guys have heard of the New York Classic Heart Association, the heart failure scale. This is what we use for atrial fibrillation, how we scale our symptoms. Okay, so again, if you have patients with no symptoms or asymptomatic, you're going to go 0, and then you're going to base on the severity of the symptoms, you're going to give them a point out of 4. And 4 would be patients who are very severe, can't get out of bed, aren't able to make it out more than around the house. Like, that's how severe people can have symptoms from atrial fibrillation.
So sorry, do you count each of those as like 1?
No, the severity. It's based on severity. So again, somebody can have, oh, I get palpitations that last for about a minute, and I notice when I'm getting the palpitations, I have 2 out of 10 chest pain. I would still say that that was like a minimal effect. And you're looking at the quality of life things for these patients, right? So if you have a patient who's walking around, they're pretty fine, able to do most of everything they would be doing in day-to-day life, you're going to give them a pretty low score. But if people are telling you, I can't even go for a walk around the block, or my palpitations are so bad, they keep me up all night, you're going to go up on severity. So causes are things that you're going to find typically in the atrial fibrillation patients there are things that are modifiable and non-modifiable. So modifiable, things that we control and give medication for, things like high blood pressure, sedentary lifestyle, so encouraging patients to do activity. And what they say for age over 65 is to do 5 times a week, 30 minutes of some sort of activity. Okay, that's a recommendation. And I think a lot of people probably don't do that, so that's something that we can encourage on a lifestyle management level. Alcohol use, and so a good funny term here, holiday heart. So you have those patients who come in and it's holiday time and they're drinking a lot more alcohol than they usually would. In addition to all the cardiac complications that can come up, one of them is atrial fibrillation. We definitely see our patients that we do our one-time visit with. Maybe don't drink 3 bottles of wine a day, you'll be fine. Caffeine, that's also something that can be a trigger, and then smoking. So those are things that we can kind of work with and modify. Then we have obviously the non-modifiable things. As we discussed, as you get a little bit older, your risks are going to go up. If you have a family history, so mother, father, sister, brother, the risks of atrial fibrillation will go up, or atrial flutter will go up if you have a family history. And then males actually have a higher rate of atrial fibrillation and flutter than women. Pardon?
The difference in that risk in the gender? Is it 20%?
It's sort of actually, it's not, beneath it. I think it's more like not exactly the same how much.
So the other risk factors, there's some other risk factors here for atrial fibrillation. So sleep apnea, as Pam mentioned, in the atrial fibrillation clinic, this is something that we would screen our patients for. COPD, and again, thinking about the pulmonary veins and the left side of the heart. So if you have any lung issues going on, they're going to increase your risk of having atrial fibrillation. If you have any issues with your heart valves, previous MRIs, so this is something that we're going to see in CCU. When you have your patients that are having MRIs, they come out, they develop atrial fibrillation. Previous heart surgery, so maybe it's for CSICU, those patients that are coming out of surgery, develop atrial fibrillation post-op. And thyroid dysfunction. Again, this is something that we check for in the clinic, is we'll do their thyroid levels, because that's something we can treat. And sometimes just a treatment in and of itself of the thyroid will allow us to treat the atrial fibrillation if we get rid of it. We classify atrial fibrillation and flutter in a few different ways. So this is what it's all in terms of timing. So Paroxysmal means that the atrial fibrillation is lasting less than 7 days and it's coming and going. So these are the patients that are in and out of it, okay? And then we have persistent atrial fibrillation, and that's the atrial fibrillation that tends to last longer than 7 days, and it usually requires some sort of intervention. So these are patients, they're in it, they usually need to come in and they need to get a cardioversion done, or they need to get a whopping dose of a rhythm medication. Usually some sort of intervention has to be done to get them out of that rhythm. These patients aren't so easily, they're not the patients that are likely going to be spontaneously converting back to sinus rhythm once they've been in it for longer than 7 days. And then we have permanent atrial fibrillation. And permanent atrial fibrillation is when the decision has been made for the patient, with the patient and the care team, that they can be in atrial fibrillation, and that will be their underlying rhythm. And I think a lot of people have probably seen those patients when they're looking after them, at least in the cardiac sciences department. That is something that we see often. I'm not sure what your guys' experiences are in the community, but this is something that happens. It are patients who have, again, the chronic atrial fibrillation. And then we have atrial fibrillation that's non-valvular, which is going to come more into play when Pam talks about the blood thinners. But just keeping in mind that atrial fibrillation, in the absence of rheumatic mitral stenosis, a mechanical or bioprosthetic heart valve, so any valve replacement, or mitral valve repair, that's considered non-valvular. So keep that in mind for when Pam does her talk on the blood thinners. It's going to be important. So why are we treating atrial fibrillation? What's the point with atrial fibrillation? Why do we want to treat it? So one, we want to identify any underlying causes. So when we talk about thyroid function, if you have other underlying causes or risk factors that make atrial fibrillation a little bit more common for you, are those something that we can address and possibly treat and get you out of the rhythm? We want to relieve those symptoms, so those quality of life things. When we did that at the SAF scale, the 0 to 4, if you're higher up on the scale, we want to do things to help improve your quality of life. We want to prevent and reduce these tachy-induced cardiomyopathies. So again, atrial fibrillation and atrial flutter tending to be fast rhythms. They're making your heart work a lot harder. So if you're thinking about the left ventricle, a normal ejection fraction is usually 60% or higher. So if somebody's having having tachy for a long time, what can happen is that ejection fraction can start to get worse and worse. And so sometimes it can go just down to 50%, and we're kind of catching them. And more we diagnose as heart failure if that ejection fraction goes to 40% or lower. And that can happen just with people being in fast rhythm. Okay. And then the other thing that we want to do is reduce and prevent emerge visits, and hospitalizations for atrial fibrillation patients, because this is something that is manageable as long as people are able to access proper resources. Okay. And then the big thing is, the other big thing here is stroke prevention, which again, Pam will be getting into. And keeping in mind how we talked about atrial fibrillation being something that is progressive and can be progressive, same with the treatment course, right? So you're not necessarily going to trial one treatment and that's going to be perfect for that patient the entire time. You're going to have to evolve your care plan as the patient's symptoms evolve, as the patient's atrial fibrillation or flutter evolve. So rate versus rhythm, I'm going to try to speed it up a little. So management of atrial fibrillation, where there's two main things that we have here. We want to manage the arrhythmia, and we're going to focus on rate and rhythm control, and then the assessment of stroke risk, and that's what Pam's going to talk about. So I'll do the focus on the rate rhythm control strategies. So historically what they did prior, throwback to the 90s, what they used to think is that rhythm control was the way to go. Because if we got you back into sinus rhythm, you feel good, you wouldn't have a risk of stroke, your exercise tolerance would be great. It was thought that rhythm control was the gold standard of treatment, gold standard of care. And actually rate control was thought to be kind of the substandard care, what you would do after all rhythm care strategies had been trialed. Rate control was kind of like what you would do after as a last-ditch effort. So in come the trials. So they did trials and they compared rate control and rhythm control, and they're looking at outcomes and they're seeing, is one group living longer than the other? Is one group having more risk of stroke than the other? And when they did these trials, they did 4 trials here which actually showed that there were no differences in stroke risk or mortality in rate or rhythm control patients. And actually they found rhythm control patients were hospitalized a little bit more often because the rhythm control medications, which I'm going to get into a little bit, are the stronger medications, and they're the medications that you're going to have lots of side effects from. So those patients were actually hospitalized more than the rate control patients. Okay? So rate versus rhythm, even though, you know, there's rate versus rhythm, there's not necessarily one that's better than the other. There are times where we prefer rate control and are times where we prefer rhythm control. So if you have persistent atrial fibrillation, and again, that kind that's lasting really long, the first thing you'd want to try is to try and get that rate down, see if their symptoms improve. Okay? Recurrent atrial fibrillation, if they have minimal symptoms, start with your rate control first. People who are older, or they failed previous antiarrhythmic drugs, and patient preference. So some patients might prefer to try a rhythm control strategy. We definitely want our patients to have a say in the care that they're receiving. And same with, so for rhythm control, is more that in and out of atrial fibrillation, if they're having first-time episodes, severe symptoms, under the age of 65, or they haven't tried an antiarrhythmic drug before. These are patients that we would like to trial rhythm control strategies in. So first is rate control strategy, and for the CCS guidelines here, what they say is that we need to do a rate control strategy to keep our heart rates under 100 beats per minute. That is the goal, that's your target. And they did do studies where they compared patients where they did a strict, more 80 or lower strategy for rate control, or they let them be a little bit more lenient and let them be under 100. And they found no differences in outcomes. So our goals are 100 for the Canadian Cardiovascular Society, but some of the other cardiovascular societies, like the American Cardiovascular guys, want to keep the heart rate to 80, but ours is at 100. So in patients who have not had an MI or LV dysfunction, which I think is rare in a cardiovascular or cardiac sciences program, if they haven't had a heart attack or if they don't have any LV dysfunction, you can go ahead and either trial beta blockers or you can go and try a calcium channel blocker on them. Okay? But if the patient has had an MI or has LV dysfunction, the recommendation is to go for beta blockers. That's what you want to try, that's what you want to put them on, because there's other benefits to the beta blockers. And then our good old friend digoxin, something that shouldn't be used as initial therapy, especially for active patients. You might want to trial this more in patients who are sedentary, but it's not something that we would want our young active patients to be on. And it should be used in patients who, like I said, who are sedentary or if they have LV systolic dysfunction. You can use digoxin. So, rhythm control strategy, when do we use this? So let's say you've got a patient, their heart rates are quite high, you've done your rate control, you've got their heart rates controlled, and they're in a good rate control strategy, but they're still having symptoms. That's when you're going to look and see if the patient is appropriate for the rhythm control strategy. Okay? This can be for recurrent atrial fibrillation and for patients who require long-term rhythm control, that their preface, their symptoms are improved when they're in a normal sinus rhythm, so you know that the goal is rhythm control with that. Okay? Keeping in mind as well, rhythm control drugs can make flutter worse because they favor organization of the atrial flutter. So even though we're giving medications that are supposed to get rid of the fibrillation, they can induce flutter. Okay, it's a little bit confusing. We'll get into a little bit more here. So the antiarrhythmic drug strategies, there's 2 ways in which we do it. We have pill-in-pocket strategy. So pill-in-pocket is appropriate for patients who are having episodes that are infrequent, so once a month or less, and they're very aware of their symptoms. So when they're having those palpitations, they know they're having those palpitations or that chest discomfort or that chest pain. It's not appropriate for patients who don't have symptoms because you want to take the medications as the symptoms come on. So you would get a big whopping dose of a rhythm medication with this strategy. So these are examples of some of the rhythm control drugs that we would use. So flecainide and propafenone are the rhythm control drugs that we would use either pill in pocket or we can do daily rhythm control strategy as well. Okay? And other daily rhythm control strategy medications are sotalol, dronedarone, and everybody's favorite amiodarone. So when you're doing a rhythm control strategy, you want to make sure that you know that your goals are to reduce the symptoms. It doesn't mean that you're necessarily going to get rid of all of that atrial fibrillation, but you're giving that person a better quality of life and you're improving their overall symptom relation with the atrial fibrillation. Cardioversions. So trial of cardioversion might be a good way to do a rate, to determine whether you should do a rate or rhythm strategy. So sometimes it's hard to decipher when people are, especially when they're giving vague symptoms, whether a rate control strategy would be appropriate or a rhythm control strategy. So this is where we can do a trial of cardioversion. So in patients who come to the emergency room, if you've had symptoms for less than 48 hours, your stroke risk or your risk of having an embolism is 0.7%. So we can go ahead and we can do the cardioversion and we're not worried. But if you've had symptoms for longer than 48 hours, or we don't know how long you've been in the atrial fibrillation, like for those patients who are asymptomatic, then we don't want to risk it. We don't want to chance the fact if you have a clot and we shock you and that clot kind of flies off. So we're not going to risk it. What we would do is get the patient to go on 3 weeks of oral anticoagulants, 3 weeks prior, and then for 4 weeks after cardioversion. Okay? And then regardless of whether you get sinus rhythm or not after you cardiovert them, you're still going to go through and look at the CCS guidelines, see does this person need to be on a blood thinner or not. So again, for patients in the emergency room who are getting cardioverted especially, you're not going to send them home on no anticoagulations if they have a CHAD score or the algorithm shows that they should be anticoagulated. Okay, so what would we do for an unstable patient who needs a cardioversion, but they're not on a blood thinner? Like you absolutely have to do a cardioversion on this patient, their rates are 160, you've tried all the medications, they're not on a blood thinner. What would we do? Yeah, you would do TEE. So you would do the ultrasound, the transesophageal echocardiogram, and you would rule out an embolism that way. And what would we do for blood thinners? So you've done the TEE, there's no clot there, you've done the cardioversion. What would we do for blood thinners for the 4 weeks after you've cardioverted them?
You don't need it.
Yeah, you actually, so kind of what I'm alluding to is, these are the patients where we might do bridging strategies, where you would put them on the heparin and bridge them to Coumadin, right? Because with Coumadin, you want your INRs 2 to 3. So these are the patients that you might do bridging with, and then Pamela did a little bit more into the new oral anticoagulants where you wouldn't have to worry about that.
So the question may be to me that why do we do have put on blood thinners afterwards? Basically, your atrium sort of stunned a bit, right? And so the ability to form a clot, as like with an MI, stuns the heart before it starts pumping again normally. So that's the same thing with AFib. You're irregular rhythm, you got the person back to normal rhythm, they're stunned, potential clot. That's why we have to anticoagulate for 4 weeks afterwards. Sorry.
Okay. So ablation strategy. It's really difficult to see this. I think this might be in your guys' handout. So ablation is a procedure that we do to treat atrial fibrillation. And when would we do it? We would do it when patients, for atrial fibrillation for patients who have failed an antiarrhythmic drug and where rhythm strategy is a preferred strategy for the patient, we would work them up and see if they're appropriate for ablation. So atrial fibrillation ablations are effective in 70% of patients after one procedure. So they get one procedure, 70% of our patients are fine. Some do require more than one procedure. We have had patients who have had 2 procedures or 3 procedures done to ablate all the fibrillation. The risk of any serious complication is less than 5%, so there are low risks with this procedure. And some people find, so once you do one procedure, because we're changing things with the electrical circuits of your heart, medicines that didn't work before might work after an ablation procedure. So you might not have to go to that second and third procedure because the medicines that weren't working before may work now. This is just a little diagram here which will show you again that for the different types of atrial fibrillation that we want to make sure that you are trying first-line drugs, antiarrhythmic drugs, before we jump to ablation procedures for fibrillation. So what's happening for fibrillation ablation, it's pulmonary vein isolation, that's what we call it. And what happens is they come up through, kind of like when you're doing an angiogram, but they come up through the vein. And they're coming up and they come into the right side of the heart. There's a little puncture made, a septal puncture. And then they're going and they're either burning with radio frequency, so with hot, or they can do a cryoablation where they use cold. And what they're doing is they're creating little scar around the pulmonary veins. And what that scar is doing is it's fencing in that electricity, and that fencing in prevents it from getting out. So the idea would be that the sinoatrial node takes over and you would be back in normal rhythm. And why that works is the electrical impulse doesn't cross scar. So scar tissue it's not conducting that electricity. Okay. Atrial flutter, it's a little bit different. So the success rates with flutter are so high. They're 90 to 95%. So our thresholds for offering people flutter ablation are a lot lower than what we would for atrial fibrillation. And we do actually offer flutter as first-line therapy. The risk of serious complication with flutter ablation is about 1 to 2%. So it was less than 5% with the fib, 1 to 2% here, and again, a 90 to 95% cure rate, which is pretty great, right? So flutter ablation, again, happening in the right atrium. So again, the same idea. They're coming up, but they're not having to cross over here. They're just coming to the right side, and they make a line here that's called the cavo-tricuspid isthmus line, and they burn this line. And what that's doing is it's disrupting that cycle. So it's, again, we said that counterclockwise, kind of going on the racetrack, it's stopping that. It's like you're putting a blockade right there, and again, you're letting that sinoatrial node take over. There are certain circumstances where fibrillation or flutter patients need pacemakers. So when you have patients who have sinoatrial node disease or AV node disease, like people who have tachybrady syndrome, right? Those would be patients that might require pacemakers, people who are symptomatically brady, or where medication cannot be optimized because their rates are going so slow. So sometimes we get patients who aren't on any medications, there must be some, and their heart rates are so low without any rate control, they sit in the 50s or 40s. It's probably because they have some underlying sinus issue or AV nodal issue. So it makes it hard for us to help control their rhythms and make their symptoms better, right? Give them a good quality of life if they're symptomatic. So this is where we think about pacemakers. AV node ablation is something, you have to have a pacemaker if you're getting this type of ablation done. This is kind of end of the road ablation. This is when you've exhausted all your resources in terms of what you can do. You would want to do pulmonary vein ablations first, try all your other ablations before you jump to this one, because this is the ablation where you would sever here at the AV node, and you've stopped any communication from the atrium to the ventricles, and it's just going to be pacemaker. It's going to be paced, all paced, right? So the idea would be to disconnect and hopefully get symptom resolution for the patients. This is a little handout that you guys all have. Everybody who picked up a handout. It just gives you a little bit of an easy flow of what we do for atrial fibrillation management, right? So again, symptoms, we want to attempt with rate control first. Do the symptoms resolve? No? Then what do you do for paroxysmal? What do you do with persistent? And whether you continue with rate control or rate control strategy. So it just gives you a quick little overview of that. Thank you. I'm going to hand it over to Pam and let her go over there.
Wow, 51 minutes. Well, I have 10 minutes to do my talk. I'm kidding. Can everybody hear me? So if I can't hear me, you can't see anything, let me know. Put your hand up, ask questions. So Kimmy did an awesome and thorough job on AFib and how we treat when they first start with those symptoms and how we treat and improve their quality of life, okay? So the next part of our clinic is that we look at anticoagulation. So again, we have our friend here, Nancy. She's a 7-year-old, lives alone, comes in, she does have AFib on ECG and she's hypertension. So what do we do with this lady now that we've diagnosed her? We're going to help her, we're slowing her heart rate down, she's going to feel fantastic. Now what? Well, what we know when we look at the Framingham, that's a long study, looks at cardiac risk factors. What they found out was that after 35 years of following these patients, they found that with increasing age, you have increased risk of stroke. And so knowing that, we know that people who have AFib have 5 times chance of having a stroke, and AFib with 15 to 20% of strokes with people with AFib. So that makes sense or not? So basically you have 5 times chance of having a stroke. So when most of the times when I tell my patients they have an increased risk of stroke, I say we have to go on blood thinners. And then a lot of people say, well, I'm not going to worry about it because I have a stroke, I'm going to die. Well, unfortunately, only 20% of those people can die from a stroke. And actually 60% are disabled. And of those 60%, they wish they were dead.
because it is devastating. And the people in neuro, you guys know this all the time. When Dr. Teal works on there for that week, because we do talks together, and it's always amazing. When he does our talks with me, he actually has that week of people who've had a stroke from AFib. And he has these amazing pictures of these horrific strokes. And you know, it's really hard to get across to them about that until they actually see a patient who has one. So, and as you know, people in neuro, is that actually the worst strokes are embolic, that are from AFib. And from this slide here, you can tell that the embolic here, their years of stroke and survival goes down from embolic. And where does this clot come from? Okay, so basically this is the left appendage. So you know how we have an appendix off our intestine? Well, this is the appendix off the left atrium. And basically when the heart fibrillates, there's stasis. And basically a clot is formed. And this, on my screen, it looks fantastic here, but here, not so much. This is the dark side here of that stroke. And so it is pretty profound. So then how do we figure out these risks of stroke for these patients who have AFib? Well, we use the CHADS VASC. And what that is are ways for us to figure it out. So basically, CHADS means C for congestive heart failure. Anyone has ejection fraction less than 60. No one's going to have 100%. Just want to let you know, people who don't work in cardio, EF, ejection fraction is only 60. That's the best you can get. So if yours is less than 40%, you got heart failure there. And then hypertension. This is treated hypertension. This is not people found with high blood pressure. These are people diagnosed with well-rate controlled high blood pressure. And over the age of 75, and people with diabetes and stroke. So these are things we look at, and we add up the numbers. So if we add up our numbers, this you get a chance for 0, you get 1 point, 2 points, 3 points. This tells you your risk of stroke annually. So if you had 2 points, so let's say you're just 75 and have high blood pressure, that's almost like everyone. So that gives you a 4% annual risk of stroke. You're thinking, yeah, so? So basically that's what my patients say when I do the education class, 4%. What does that mean to me? In my education class, I have at least 25 people or more and who have AFib. And I tell them, okay, majority of you here, put your hand up and you had said you have your CHADS score of 2. If you do not take a blood thinner, 1 out of 25 people here will have a stroke. And I said, look at your next person next to you. One of those people will have a stroke if you don't run a blood thinner. And it's like, holy crap. The light bulb goes off and you realize it. And it was even more evident when I had one patient who was a GP. And he had a CHADS score of 2, and he would not go on a blood thinner. He would not go. He said, forget it. I know I'm doing Pam. I called his colleague who's a GP, and I said, hey, you know what? He needs to be on blood thinner. And on his way to, and I said, you know what? Humor me. Come to my education class. Tell me what I'm doing. Tell me what I need to do to encourage more people to go on blood thinners. Well, unfortunately, on his way to my education class, he had a stroke.
Oh my God.
Yeah, and let's just say, and I love you guys, and I know you're probably thinking, oh my God, you're singling this out. You guys actually made sure that guy came to my education class. You got his brother and sister to bring him over. Because when they rolled him in, because they had AFib too, they rolled him in my education class, you see this guy like this? Okay, do you know what the 100% uptake of anticoagulation was that day? It was amazing. But yeah, so what I do is very close to dear to my heart because honestly, I was so upset. An intelligent man would not go on a blood thinner. And you guys see it all the time. And every time he spent like 8 months in Holy Family for rehab, and every time he comes and sees me, he says, I should listen to you. What do you say to that? So. Okay, so then what came from that is the CCS guidelines that talked about CHADS score. Okay, so what if you get 0, Pam? When you have 0, so your risk of stroke with 0 is still about 1.9%. So how low is low of not having a stroke? So we added 3 more things on. So we looked at CHADS VASC. We looked at someone who is over the age of 65, and then we looked at someone who had an MI or peripheral vascular disease. They get another point. And then unfortunately, as females, we got a point. I know. As they say, it's supposed to increase the risk of stroke. So we were using that. People in the States and Europe, they were using those guidelines. Okay, so lo and behold, why you're here today is that the new guidelines came out October of last year. So what has changed? So what has changed the most is that we sort of use CHAD score, but we use a bit of CHAD fast. But bottom line is we're using the algorithm, makes it easy. Anyone over the age of 65, boom, you're going to be putting them on a blood thinner. That is new guidelines. The studies show that anyone over the age of 65 increased risk of stroke. 65 is first thing. Stroke, hypertension, heart failure, diabetes, right away, you go on blood thinners. If you had a heart attack or any peripheral vascular disease, you would go on aspirin. And do you notice now? The women are not inferior gender anymore. We're now even. We're now off the scoring system. So females and males are all the same when they did a study in risk of stroke. So the biggest thing here, the biggest take-home message, if you guys remember, 65 AF, be on blood thinners. And that's one of the things in Emerge that they're trying to do now is with the guidelines is that if a patient with AFib is 65, you need to start them on a blood thinner. Okay?
What if someone's a beginner, like they had an incident of a cardioverted person and they had pre-open heart years ago, and they've been put on blood thinner for 3 months? Do they continue if they're in their early 60s? Like 60, they're 60. So it's a one-time event, but obviously
So
hypertension.
they don't have that, or do they have that?
Well, not AF, they have spontaneous, meaning on a spontaneous event, they went into AF, went to the hospital, they cardioverted him. But he has a history of open heart, history of hypertension.
So if he has a history of hypertension right there,
He gets it.
you get it.
And you get it you just keep
For
on
life.
going.
Yep, for life. Yeah. Yeah.
Because of the fear of him spontaneously going
If you have
into-
hypertension, I guarantee you're going to have AFib. Hypertension is, think of, I'm totally deviating, and this will be more than an hour long. I do apologize. If you guys need to leave, I totally get it. But this is really important. Think of Arnold Schwarzenegger. You know how he builds up and he's all bulky, right? You're probably thinking, where are you going with this pound? Okay, so you're probably thinking, not that he's very good looking or anything like that, he's whatever. He's just really bulky. So think of this, he's working really hard, pumping weights. Think of your heart. Think of blood pressure. Your high blood pressure, your heart's pumping really hard to pump the blood up. What's going to happen with that? Actually, your myocardium becomes thick too. So basically, you get this thing called a diastolic dysfunction where your heart can't relax. So when that happens, not only are you pushing pressure to make that myocardium thick, you're also pushing it up, the pressure up to the left atrium, and that enlarges. And Kimmy was saying, if you're near the pulmonary veins, and if you disrupt anything like that and make it bigger, automatically you can cause atrial fibrillation. That's one of the main things that we do in our clinic is to monitor and maintain high blood pressure. Guarantee you got high blood pressure, you're going to get AFib, regardless how long or how well. Right away, we actually put patients on blood thinners. Sorry, let's go back. One of the things is you're thinking, okay, can we talk about the risks of stroke, but what about bleeding? We used to do we do the hazard blood, we do look at it, the risk of bleeding. A lot of things can be modified. We look at our kidney functions, hypertension, that's something that can be fixed. Alcohol, drugs, that can be fixed, decrease your risk. High blood pressure, anything greater than 165, that can be fixed. If the INRs are labile, that can be fixed with another drug. So anything can reduce your risk of bleeding. You can actually do it. Okay, so when you weigh up the balance, and they say, oh my God, the risk of bleeding is so high, you think, okay, but how can we change things to make it less, to prevent stroke? Yes?
What about somebody with diverticular disease?
Sorry?
What about somebody with diverticular disease?
So then we have a lot of people who have hemorrhoids or whatever. Sometimes we get them to actually get that fixed and then deal with that. And to be sure the GI guys, we actually go that route to ensure that we can start decoagulation. Because that can be a problem. So again, with our famous Nancy here, now that she has AFib, see her age of 70, she's got hypertension, her ECG shows AF, what are we going to do next? Okay, yay! Okay, you guys are like little anticoagulants. It's like, seriously, I'm so excited. You guys should be yelling this out. Okay, but what's the CHAD score? Why would we anticoagulate her? Why?
So she is
Age and exactly. Okay, yay, you did learn something. Yay. Okay, good. thinking he needs to be on blood thinners. Now you're thinking, okay, which drugs are out there? Okay, so aspirin, obviously, that's not going to happen. Then you might get some person may say, well, how about Plavix and aspirin? Okay, that was a possibility. The study that was done, dual platelet therapy, where they looked at aspirin and Plavix. They did look at that, which showed obviously that the aspirin and Plavix did reduce the risk of stroke, but increased the bleeds. So then they did one with aspirin and Plavix and warfarin. And what did they find? Well, actually increased the stroke risk with the Plavix and aspirin, and the bleeds were no different. Because people think, well, at the time, I mean, these new drugs, these novel agents haven't been out that long. Obviously, there must have been something else besides warfarin, and there was. But as you can see, the superior drug was warfarin. And you're probably thinking, where the heck did that drug come from? Because we've been using it for decades, okay? So basically, out in a cow pasture, cows were falling over and bleeding, they were lying there dead. And what they found out, Wisconsin University found out, was that they looked at the clothes that they were eating. The moldy clothes caused the bleeding. And so where did that, what happened with that? Well, that's where warfarin came, rat poison. And so a lot of patients right now who are the ages of 70 to 80s, even the 60s, what do they remember? Warfarin has rat poison. And so you can imagine, a lot of these people don't want to go on it because they think, oh my God, I'm going to have this, I'm going to die from bleeding, just like a rat poison. And that image makes it very difficult for patients to go on anticoagulation. And it's funny, the first thing they say, rat poison, not going on it, don't even go there, pound, not doing it. Very common. So what do we know so far? Well, we know that obviously if we go on nothing, 100% risk of stroke, and it goes down as we go from aspirin and the dual therapy and then warfarin, 30%. But you know what we found out is that actually anticoagulation is being underutilized. And basically, as we saw the framing and risk score, as we get older, our risk of stroke goes up because of AFib. So you'd think we'd be targeting those people. But what we found out was that they're not being targeted. Only 20% were actually going on it. That's just crazy to prevent stroke. And so when they looked at things, they showed, 60% of people did go on it. And then once you actually went on it, they actually, 50% of that actually stopped it because for numerous things. And so what they found out was that a lot of the people were under poor control. They stopped it because they didn't like in their blood tested. They weren't in the target spots. It was impossible to get them there. So a lot of patients stopped taking it, which is sad because they're the ones who mostly need to be anticoagulated. And when we looked at stuff, what we noticed that only 10%, and even those people who are actually therapeutic, and people in neuro probably see this all the time, even though they're therapeutic, how many of you guys see strokes? A lot of them, right? So it's sort of, it's interesting. But a lot of times people are super or supra-therapeutic, people will be on none and on single agents. So there's a small group of people that are actually being anticoagulated. So we need an alternative to warfarin so that we have better compliance to prevent stroke, because we know it's a huge thing. So what is there? So this is the anticoagulation cascade. So you can see where we can prevent the fibrin to clot. So with the new drugs that are out now, rivaroxaban, apixaban, the Digatran. Rivaroxaban, apixaban, the 10A, can't really see it. On my computer it's fantastic, but here, not so much. It actually prevents that clot for the 10A inhibitor, and Digatran is the 2A. And those are the drugs I'm going to talk about as alternatives to warfarin. So this is just a quick little sheet that I like to show because it shows all the novels there. So the first three here, you have your 10A inhibitors, your rivaroxaban, apixaban, doxaban's not quite out yet. And then you have your Digatran, which is a dominant inhibitor. What's to note here is that bioavailability is more rapid in the 10A versus the Digatran, only 6.5. And please note that these drugs, the onset is quick and so is their offset, not like warfarin. How long does it take warfarin to get in your system? days, and you have to bridge and everything like this. This, after 1 or 2 doses, you're anticoagulated and you're preventing a stroke right there. One thing that I do want to mention is the renal clearance. So one of the things is with the Bigatran, 80% renal clearance. You gotta watch your kidneys, okay? Because that can cause problems. You can't get rid of it, overaccumulation, not so good, okay? And so I'm just gonna go over the different types of anticoagulation. So there is Apixaban, Eliquis. It's 2.5 twice a day or 5 milligrams twice a day. The reason I'm mentioning this one here is that's the only one that went head-to-head to aspirin. All the rest of them went head-to-head to warfarin. What's interesting with Evro's study that because it went head-to-head to aspirin, no kidding, that it prevented stroke. Way better than aspirin, we know that. But what's interesting was that their bleeding risk was no different from aspirin. Okay? Then they went to the head-to-head with Aristotle with warfarin, and I'll give you all the stats, and I'm not going to bore you because I swear to God, it's the Cole's notes, what you need to know, because I don't want you yawning at the stats. So the big thing you need to know is Apixaban and warfarin Aristotle trial, it was a good trial that showed that it was effective in preventing stroke. And then there was the Bigatran, or Pradaxa, the one that states got all that hoopla about, oh my God, doing it sued and everything else. They were put on the wrong patients, wrong dose, for the wrong reasons. And this is why we're here today, is to know which ones are the best ones for the patients. And so that was the Bigatran, and the trial that they were the first one out to be one of the first anticoagulation novels, and it was the Rely trial that went head-to-head to warfarin, the first one ever out. Okay? And then there is Rivaroxaban or Xarelto, and this is the only one that's a once-a-day formulary, which is great for compliance with most patients. You know how they forget the second dose? It's always good to have one dose. This is a great one for that. And that was the Rocket AF trial. Okay? So one thing I do want to talk about, I want to compare the two. When you look at studies, you're probably thinking, oh, they're so, you got to figure out what's the right thing. You can find anything you want in a study, but I'm going to give you the Cole's notes. The difference of the two, between the Rely and Rocket. So both of them, they were both non-inferior, meaning they're just as good as warfarin or even better. Okay, that's what we found out. And that they were great at preventing stroke. So basically, what we need to know is the different trials. What I found out was with the Rocket study, their CHAD score, meaning they have more comorbidities, more risk, were higher than the Rely was the Bigatran. So basically, you're looking at 83% of the patients had a CHAD score of 3. Either age, hypertension, diabetes, they were the sicker bunch. With the Rely trial, they were younger and less risk. And so they were healthier. And so it's important to know, and also these people in the Rocket trial, they had about 55% of people may have had a previous stroke, where the other one maybe 20%. So when you look at that, you're looking at the risk, you look at your population, look at your patients, determine which is the better drug to use. Okay? And then another thing is we look at trials, it's always do a blinded study, not knowing. The Rely, the Bigatran was not. Okay? So in summary, thinking, oh my God, Pam, my brain's overfilled with all that junk you just told me, what do I need to know? Okay. What you need to know is that obviously with the newer drugs, the risk of stroke lowers tremendously. Okay? The Bigatran and Apixaban, less major bleeding, similar bleeding between the Bigatran, 150, and Rivaroxaban. But the biggest thing is less intracranial bleed, because we know warfarin increases intracranial bleed, for sure. So again, when we look at all the studies, and this is all the drugs and their doses here, basically all of them, this is your confidence line here, all of them prevented stroke, and they're better than warfarin, okay, or non-inferior. The biggest thing, intracranial bleeding, all of them prevented that versus warfarin, better than warfarin. And all-cause mortality, big thing, all of them were better with the novel agents than with warfarin. Okay? These are the most important facts that you guys need to know when you're thinking about starting patients on blood thinners. Okay? So then you're thinking, great, you told me what it does, Pam. How do I figure out for the right drug for the right patient? So things that you consider. He looks a little grumpy here, but he's not really grumpy. So So what we look at is, Kim had mentioned, valvular AF versus non-valvular AF. So basically, if someone has a mitral valve, stenosis, or mechanical valve, they cannot go on these novel agents. They can only go on warfarin. The Bigatron, that company Boehringer, they did a study looking at mechanical valves with their novel agents. They had to stop early because they actually caused a stroke and clot. So no one else has done it. It's done. Warfarin right now seems to be the only one out there. With the rivaroxaban, what they did was in their rocket study, people who had a repair to the valve, okay, not replacement, repair, they had a small subset. They actually had patients in that trial, which showed to be okay. So some patients that I have, or some cardiologists may feel comfortable with patients with a mitral valve repair to be on rivaroxaban. Okay, that's the only drug that can possibly be on there. So then we look at things to consider is that coronary disease, they had stent put in, or let's say if they had a clot busting TPA, what drugs are going to put them on? So you have to think twice about which drug. Is it going to be warfarin? Is it going to be a novel agent? It's a conversation that needs to be had. People who have who've never been on warfarin before, or if they have liable INRs. These are things that we think about as to which drug. And this is what I do every single day with my patients. And it's a conversation we have together. I just don't tell them, boom, you're going to go on this. It's a conversation of what's going to work for them. Because there's also things that we consider. Like if someone's going for a procedure like a cardioversion, okay, having an INR between 2 and 3. It's to get that sweet spot for once a week, making sure everything's okay before you do the procedure. How is it all the time? People in the recovery room will know this, is that right before you do the cardioversion, you check their INR and boom, it's 1.8, 1.9, and you're like, I said that because I don't want to videotape. That you're going to have to cancel if your risk of stroke is there. And then that means you have to cancel the procedure, and then you have wasted everybody's time and everything, especially if you don't find out that day. So with me, using the novel agents are awesome. It's a guaranteed, boom, you're going to have your procedure. And then this may be also with the ablation patients that we may think about. Those are the excellent drugs to use, especially when we have some of these patients who, I don't know, do this. This is what this one patient did, and I can tell you this right now. He decides to, it's been so good for 3 weeks in a row, he decides, I'm going to tie one over. I'm going to have a 40-pounder of rye whiskey, I don't know what it was. Anyways, the minor jumped up to, it was like 6. So of course, he goes, oh my God, I'm bleeding, I'm peeing out blood. What does he do? He goes to emerge. What they do? Give him vitamin K. He didn't tell us. And then his INR was like 1.2. So we had to cancel his procedure. So those are things to think about. Also, practical things. These drugs are cheap. These come with a price. The average price is about $100 to $115. Walmart, Costco, cheapest places to get their drugs, especially if you get these ones here. Okay, it does cost. Yes? Per month. Per month. Especially if they're in a tight budget and they don't have third-party coverage. Sometimes if they can, if they've been on warfarin, their INR's laying low, and they're out by 30%, we can get special authority for them. But they have to meet the deductible. Okay, so that's the hard thing. And but when you think about it, think of the patient's time when they get their INRs checked, right? You know that when they go to lab, they actually have to make an appointment. They can't show up anymore. You have to make an appointment. You have to get there, take time out of work. You have to get your blood tested. Then you gotta wait for the doc to call you. Is that doc gonna call you? Wait back and forth. So that's time. That's almost as much as the cost of that drug. So let's go back to this guy here. Typical guy. He's on warfarin now, right? He's gonna be going and seeing his GP because he needs a renewal of his warfarin and he has to get his INR checked. And so now he needs a new rec. So then he heard on Dr. Oz. My mom loves Dr. Oz. Okay, he thinks he's the bomb. And basically, I can tell you right now, my mom's a retired nurse. She thinks Dr. Oz is God. And so she says, oh, Dr. Oz said this, oh, we should do this. And you won't believe my patients actually say that to me. Dr. Oz actually said I should do this. So basically, what does that mean? If someone's getting their INR tested like once a month, right? You're thinking, well, they say, well, what's the point of switching over? Should I or not? And I get this question all the time. Basically, if you were in a therapeutic time between like 65% of the time, 65 to maybe 70, your risk of stroke is about 0.6. Reduces your risk by 0.6. And so if you are in excellent control, it's 0.9, so it's even less. But how hard is it to get between 2 and 3, 70% of the time? Because you guys know, what causes your INR to go crazy? Food, green vegetables, antibiotics, green vegetables, everything. Some people think it's great because they don't need to do it. I can tell you right now, if someone ever has a problem with a high INR, I get your INR down to 2.1 with a mixture of greens. I have this special recipe that we have because we were, remember when vitamin K was the shortage? And I had to figure it out. I know how to figure out the biggest bag for your bucket of green vegetables, bring that INR down like a rock. But, you know, it's really hard. It's really hard to be in that therapeutic range. So who should be using these novels and who should we consider? Well, patients who are low risk. Okay, so let's say 65 is sick. I would consider us putting the novel agents. And even the guidelines, the Canadian Gastric Guidelines, actually say these novel agents should be preferred over warfarin, as long as it's non-valvular, okay. To be on it. New patients who've never tried it before, patients who are willing to go on warfarin because of the rat poison, or their INRs are crazy all over the place. These are patients that we would consider putting them on novel agents. And so then we also have to think about, remember I talked about kidney functions? It's really huge. If your GFR is greater than 30, it's all for a game with any drug, okay, any one of them. Dose pending, and I'll show you that. If it is between 15 and 30, we would actually shy away from the novels, and we'd actually go with warfarin to monitor it. And if you're less than 15, you got the crappiest kidneys ever, I ain't gonna put you on aspirin or warfarin, nothing, okay? So choosing the agent, you have kidney disease, and I really apologize, guys. You guys are hanging in here. I'll speed it up a bit. If you're for Pixaban, if your kidney functions, your creatinine counters is like 130 and above, you're looking at 2.5 BID. If for your GFR is less than 30 for Rivaroxaban, you go down to 15, not 20. And then for Dabigatran, you know, it's sort of been great for me. It's less than like between 30 and 49, we go to the 110 twice a day, okay? So you're thinking then, okay, Pam, when has it got the crappiest kidneys, the ones he's talking about, the GFR is 50, they had a GI bleed, or they have some kind of diverticulus that's bleeding and it's really bad, but their risk of stroke is really, really high. Is there anything out there for them? Well, there's this device therapy. It's called the Watchman. This is not, we talk about the guidelines, but it's not recommended, but just mentioned. This is not first-line therapy. Basically what this does is, basically, you know that appendix off the atrium? They put this little device in there. It's a, it's like a, what is it made out of? It's like a silver type of, anyways. Jackie Saw, she's one of our cardiologists and internists, interventionalists. And she actually puts these devices in. I've actually had her put one of my, 2 or 3 of my patients because they had a stroke and bleed in the brain. And the neurosurgeon said, you don't want them laying on blood thinners. So these are the patients who are high risk that I consider maybe having another stroke that we would put this on them. And so basically it includes the LA appendage, and then scar tissue forms over it, and then there's no accumulation of making a clot there. That is an option too, but I'm not saying I would never go there first thing. Every procedure is always a risk, okay? So now you talked about, okay, Pam talked about, oh my God, put them on these blood thinners, they're gonna have a stroke. Then what about a bleed? You're right. Oh, their emerge person's gone, because she'll say, yes, we have bleeding now. Well, you know what? This is no different than warfarin, okay? Everybody bleeds, they still get treated the same. So, of course, we got Anna here. She's got a GI bleed, and she's on Dabigatran. You know what? This is something that they deal with all the time. Bleeding is the same thing. Now, just remember this. Warfarin, it takes forever to come on. It takes forever to come off. And if you give vitamin K, it takes about 6 hours or more to reverse, okay? The novel agents, it's quick to come on. Last dose, quick to come off. So time is on your side. So regardless, you have those 6 hours of either one of them, either time coming out of your system or vitamin K reversing it. You're still going to treat them the same. You're still going to give them IV fluids. You're still going to give them blood products. You're going to give them PCC. It doesn't really matter. You're still going to do that. Okay? So the biggest questions that we have to figure out is how should she manage immediately? If she's bleeding and her pressure's in the boots, we're going to give fluids. And what investigation should be done? Just find where the bleeding comes from and what other interventions can we do? But the big thing is for me, for all my patients who come to my clinic, I always make sure they have an IV bracelet. They say they're on a blood thinner and which one. Because time is of the essence. Because you want to know what drug you're on. And I always tell them, spell it out because people think right away they come bleeding. Oh my God, you must be morphine. That's what they automatically think. They don't think novel agents. So that's why I get my patients wear these IVs. And so basically, time is important. You need to know what drug is on board, what dose, and when was the last time you take it, and can we measure it? And what are their kidneys, what are they doing? Are they good functioning kidneys, or are they crappy kidneys? That's going to be important. And the half-life of that drug and the severity of the bleeding. So even though I say this, I want to let you know that because dabigatran was the first one out, they did have a pathway to figure what's happening. But still, it doesn't matter which novel drug you're on, it's still the same. You treat the same for bleeding. And all the hematologists here and all the different hospitals know this is the type of pathway we follow if someone's bleeding. So basically they come in bleeding. I know it's hard to see. Obviously you're going to stop the drug. You're not going to give them any more. You're going to treat them. You're going to figure, can we fix it? Can we give fluids? Can we give blood products? And take a look. And so if they have dabigatran, we can do an APTT or hemoclot. All that will show is, yeah, it's in your system. Yeah, and so, yeah.
When it lasts daily, that you just take daily, does it take longer to leave?
They're all about 3 days.
It's all about,
That's the recommended time.
sorry?
3 days. The half-life's about a day and a half, but they recommend 3 days for full.
So someone's bleeding.
So someone's bleeding. And so basically it is out of your system by, it does the half-life, because, yeah. And so basically, what happens is, if their still bleeding continues, they can get PCC. So we can think tracemic acid, we can think of factor 7, and FIBA. And of course, if the patient has a kidney function issue, we can do dialysis. And then for dabigatran or the Atrial, it sort of sucks it all up and kind of gets some reversals. And FIBA is one of the drugs we can get. It's damn expensive, it takes time to get. Okay? So you're thinking, well, was there any antidotes? Well, even though we know time's on your side, but it's always people to feel more comfortable that knowing there's an antidote. Yes, they are being worked on. Just want to let you know right now with the dabigatran. Now I'm going to say this very slowly, and I was told how to say this. I dare you, Sismab. That's how she told me to say, I dare you, Sismab. That's the only way I can do it. And they, yes, they're trying to figure a way to say this stupid word because it's way too long. Basically, they found from rats, they found out that there's an antibody and they made it humanized. And basically what happens is that it's an IV, they give it to you IV, and basically it sops up this antibody, sops up all the dabigatran in there and reverses it. Okay? Stops it from bleeding. It's in its 3rd phase right now. Right now at St. Paul's in the trials when people coming to emerge. And if they're going for urgent surgery, they'll be using this drug. So it's in the works, and it's phase 3. With regards to the 10A inhibitors, with rivaroxaban, they have a recombinant, same thing. It attaches on to the big 10A drug and reverses it that way. So yes, they're all in trials. Yes, and you can be reassured that it will come to light sometime that there will be a reversible agent. But to be aware that these drugs are excellent, they are first line for preventing stroke with AFib patients, and that there is a way to manage the bleeding. Okay? So, as I mentioned, it's in development, and of course, I cannot help but put a plug into our clinic. So, you have any patients in neuro, in emerge, in surgery, CCU, CB10. If you think these patients refer to our clinic to be worked up for AFib anticoagulation, please send them to us.
Is it only a BGH?
There's one at BGH, there's one at St. Paul's.
Which one?
Richmond, probably come to us.
And is it GP referral or only cardiology?
GP, nurse practitioner, it can be
Is it
cardiologist.
self-referral?
Not self-referral, has to be
Oh,
referral.
it's through GP.
Yeah, GP.
Okay.
Okay? Okay, my last thing I have to say, okay? This whole talk is about, I know it's hardly like my last thing I say. It's all about prevention, okay? We're here today to talk about prevention, knowing the strokes, risk of having heart attacks and everything. That's what we do here. So this is my last thought, a funny one I hope, all about prevention.
Okay, before we get to questions, I just wanted to let you guys know about the upcoming things that we have. So, talks that are coming up. We have an in-service that one of our cardiologists, Jackie saw. She's going to do spontaneous coronary artery dissection. So she's going to do a scat talk. It'll be on February the 11th, 12 to 1. It'll be in the Diamond Center at UBC. So if you're interested in coming, send me an email. Anybody who I usually send emails to, you will get this. So cardiac sciences people will get this. If you're interested, pardon?
It's here.
It's
Oh, it's the Diamond Center for UBC conference room.
Okay, sorry.
UBC conference room. Here, at Diamond Center, sorry. It's going to be at Diamond Center, they just call it the UBC conference room. But if you're interested in coming, just send me an email. If you want to be on the email list that I send out to invite people to these talks, you just let me know, and I'll just put your email address in there, and I can shoot off an email. And then the other thing that we're doing is the education committee. So we have a cardiac sciences education committee where we try to put on talks. We try often once a month. We try to come from either nursing, allied health to do a talk once a month, and then I'll try to alternate with our cardiologists. So we need help in planning these in-services, getting people together, organizing food. We thank Jennifer very much for doing that for us today. Trying to get the evaluations organized. We want to get a newsletter together to send out through cardiac sciences. So if this is something that you're interested in, let us know. This is something that kind of started in when I was working at CCU, and I was really supported by the CCU staff to create an education committee so that we have opportunities for frontline staff. And then when I went to the atrial fibrillation clinic and met Pam, she had the nursing rounds that she did, and we've just been able to collaborate. And now as things are growing, we just need your guys' support and your guys' help, and hopefully we can keep things like this happening.
Thank you, everyone.
Any questions at all?
Cindy,
What kind of monitoring is required for patients on the new agents? Like blood work or anything like that, or?
Okay, so basically, obviously you can't tell if it's in their blood system or not, you just all by that they're taking it, it's in it. What I do for, when I do send my letters out to family docs, twice a year kidney functions. I gotta make sure, twice a year, because I gotta make sure if their kidneys crap out for whatever reason, drugs, I don't know what, that the dose is adjusted. Because they crap your kidneys wrong dose, they're gonna bleed.
Okay, so they're always on whatever the dose is for that drug?
Yeah, it doesn't change. And so you're right, if once I do my cardioversion, I say to the patient right before I zap them, I said, you did not miss a dose, right? I said, if they say no, I said, because if you miss a dose, and if you wake up having a stroke, that means you lied to me. so then they're like, no. Because I will, if they said yes, I will stop it there and I will not do that cardioversion for them. If they said they missed a dose, I will not put that patient at risk. And I do tell them before I sign them up, because I said,
Just anything that we have in Canada or North America where patients can check their own warfarin. I had family over, I'm just not around me. We had family over from Switzerland, and because him and his wife, they were traveling for about 6 months, and he had this device where he would do a poke, and he would get his INR, and then he had a thing from his dog, and he would be like, oh, I need to just change it up. And he's like, yeah, when I don't travel, this is all I do.
Yes.
And his work and his INR has been like beautiful.
If it works for them, that's great, because those strips are damn expensive.
Yeah, you did say that.
They're
But
freaking
do we
expensive.
is that even an option?
Yep, they do,
It is, okay.
Because before these novel agents, we had a lot of patients who travel, and they're like, what do we do? That's exactly what we do. They cost some money, and actually some pharmacies, they have pharmacists who actually train the patients how to do that. How much is it? They're about
Are they more expensive than the novels?
Yeah, they are, yeah. So they're about like, how much, about 4,000 or 5,000 for just the monitors, and then each strip is like $9. Wow. Sorry? Well, it depends on your plan.
Like even we're not covered for those of us in nursing, we're not covered for the new oral anticoagulants in our coverage.
No, we're not anymore. We were.
But come to the AFib clinic, we'll give you some.
So then what we do, and I didn't say this, get special authority if your INR is out by 30%. Notice I'm not near the video. I just gotta stand. If your INR,
Where there's a will, there's a way. Any other questions? Yeah.
They ever tried a bridging, someone after the cardio version or whatever, have they ever attempted bridging with novel anticoagulants and to get them back on warfarin instead of bolts at home?
no, I've never heard that one before, no. That would be very difficult. That would be hard to do.
Code Blue, Jim Patterson Pavilion, 4C. Code Blue, Jim Patterson Pavilion, 4C.
4C.
Anybody else?
Okay, what about natural things? Because my dad wanted to do some like
Yeah.
something.
Sorry, can we, Michael just asked you a question.
People come in with that?
Yes.
Of course, they want to do natural.
You had a stamp put in, yeah? Yeah.
And there was this that issue as to how to start if you did Roxanne and was on before.
Because these are aspirin, Plavix, and Roxanne.
But as to do all three of them, or just one of them, or because of the stent?
So the guys is,
That's a good question because that comes up a lot in CCU, right? Like when you have those patients who are getting the stents put in.
so you're gonna get different docs and different things. Obviously as a drug-eluting stent, you need the Plavix and aspirin. Done deal. Then we're about the AFib. So a lot of them, it depends who's on. They may feel that warfarin needs to be the best drug because you can monitor the INR, and then the risk of bleeding. Some will say go to lower dose of the novel agent.
And there are people who will take them off the aspirin and just do the novel and the Plavix.
Yeah.
Like it kind of.
That's what they ended
Yeah,
up doing. That's
yeah.
what
Yeah. So
So-
So I mean, I guess it's physician dependent a little bit. It's not exactly black and white, and
Well, it's visit dependent on the discussion with the patient. So if that's going to be individualized, a lot of times, if they have AFib, they won't put the drug-eluting stent in. They will just go with the bare metal because that's a short time. Because you're drug-eluting, you're stuck for a year of products, right? Or whatever name you use. So they would go with the drug, the bare metal because they kind of be on dual therapy loss.
good question, Michael. That's a good question.
Awesome.
I like it.
Any other questions? Thanks, you guys. I know this is a long, long day for the evening. Thanks for coming out.